Never, not ever, not in the hospital, not when they're teething. A latch should never be painful. And I think that's a big myth. People are like, no, it just hurts for the first week and that's normal. Like, it's not normal. Something's happening here. Then they're like, what am I doing? There's nothing here. I don't know what I'm sucking on. And then you get the babies who are like, I don't know what to do. I don't know what to do. I don't know what to do. And it's because they're looking for that sensation on their palate and they're not getting it. And so a tongue tie would be, there's tissue in the middle, right? And so what is the impact that it's having on that undulation of the tongue in the middle? You're very primed to that oxytocin in that first little newborn period, right? Because you have to be, because you're setting your supply, you're bonding. If you weren't primed to it, I always say, like, your baby's gonna pick the cry that gets you the most, right?
A lot of good information about supply, and then when we talk about supply, actually, what is the cause of letdown and oversupply?
Yep. So letdown, milk flow, and milk supply are two different things. So milk flow is how much milk, how fast, right? And sometimes people, when you have a letdown, it's kind of like, more milk, and then it's kind of more consistent, and then more milk, and it's more consistent. And then for some people, it's like you have a letdown, and it's like all the milk, no milk. All the milk, no milk. So it really depends on your body. Supply is the total volume of milk that you have, right?
Okay.
So letdowns are stimulated by oxytocin. So the baby sucks. That tells your body, like, there's the baby. And then you get a surge of oxytocin, and that releases the milk. Whereas supply is how much milk are you removing over time, and that's going to set it. So the biggest cause of oversupply that I see is pumping. Especially because we're in Canada. In Canada, we have the absolute privilege of maternity leave, right? 12 months, 18 months is very common here.
Yes.
In the States, our next door neighbors, right? They get 6 weeks, 12 weeks, right? And if they want their baby to have breast milk, they are, because you see people call it feeding the freezer, right? Trying to get as much of a stash of milk as they can because they want their baby to have breast milk for as long as possible. And they're going to be separated from their baby, which is so awful.
Yeah.
It's so awful.
Yeah.
But I think the culture kind of like bleeds over the border a little bit, that people think, oh, I'm supposed to pump. I have to pump to get my milk supply in. And sometimes even we're told that at the hospital, like, you have to pump to get your supply in, but then you don't know when to stop. You're not told when to stop or how or what. And so realistically, like, you only want to be removing milk when the baby needs milk, whether that's with the baby directly or with pumping. And if you're doing it more than that, that's going to increase your supply. It's going to lead to an oversupply. And if you're not doing it enough, that can lead to an undersupply. The other thing that I see that leads to an oversupply that's a little bit more like sneaky is a haka.
Really?
Yes, because those are technically pumps. They're not good pumps, right? I wouldn't use it instead of a pump.
Yeah.
But those like silicone suction things, there is suction there, right? And so if you're using that every feed, that can cause an oversupply as well.
What happens to when we are feeding? Sometimes they say feed on both sides, right? Sometimes the baby is really full from one side. We always have like one dominant side, right?
Yes.
And then in that case, can we pump on the other side? Because then you feel like something is not okay. You feel heavy on the other side, right?
Yes. So it depends. I would say, like, if it's uncommon for your baby to do one side, then, and you're like, oh my God, I'm so uncomfortable, pump for comfort. Don't do a full pump because it's more than what your baby needs, right? Yeah. But if you're just like, I got to take the edge off, I'm going to explode here, I have to take the edge off, right? That's different than you just pump a little bit. That's where a haka can be really helpful. And sometimes babies do only take one side, right? And
sometimes baby have a favorite side too.
Yes, this is also very common.
I had this problem for weeks.
Very common, yes. And it's interesting because sometimes too, if you have a body preference, or if your baby has a body preference just from like how they were in utero, then maybe they don't like to look in one direction, or maybe you don't like to hold them on one side, and these like little tiny things make that maybe they're on this side a little bit less than this side, and so then this side is producing more milk, and so this side is the favorite side. But also, it is normal for one breast to produce more than the other breast.
Thank you for saying that. I always thought, like, is there a problem in the other one, maybe?
No. It's totally normal.
Okay.
It's totally normal. Most people have one breast that produces more than the other.
Good to know.
Yeah.
One thing I would say, I'm not sure if it's a fact or not, but I read about this and I was mind blown. But you being the expert, I want to share this with you so
Yes.
that you can tell me if it's true or not. Okay. This is about mom having the mom starts to leak when the baby cries.
Yes.
Is that connected to brain? Because
Yes.
first of all, I cannot hear my baby crying. I'm like, it triggers me in a
Yes.
way that I cannot explain.
Yes, that's also normal.
Right?
Yeah.
It's doesn't trigger me in a bad way, like, oh, why are you, no. I'm like, oh my God, my baby's crying. I have to hold him
do
right
something
now. I have
right
to do
now.
something,
Yes,
right?
that's normal. That's normal.
And that's just me. Like,
Yeah.
my husband keeps telling me, it's okay, he's fine. We both are here, right?
Yes.
No,
No,
he's
it's
crying.
not.
It triggers me.
Yes.
I don't know how to express that.
Yes, I know.
But
It's very common.
especially when he cries or when he gets hungry, I already feel like, I'm leaking.
I need to feed you. Yes, yeah. That's very, very normal. It's totally normal. I always say, like, your baby's gonna pick the cry that gets you the most. Right?
Yes. But is it connected to our nervous system or our
It's connected to that oxytocin release, right?
Okay.
And also too, like the further postpartum you get, the less you're gonna have that, like,
Yes.
oh my God, they're crying, I'm leaking. Some people never leak. Leaking is like about your own physiology. It's not about how much milk you have. So some people are very leaky. Some people leak the whole time that they're breastfeeding. Some people never leak. Some people only leak in the beginning and then stop. But you're very primed to that oxytocin in that first little newborn period, right? Because you have to be, because you're setting your supply, you're bonding. If you weren't primed to it, babies are a lot of work, right? If there wasn't like an urgent physiological response in you, you would leave your baby somewhere. You'd be like, I don't have time for this. It's too much work, right?
Yeah.
Like, it sounds silly to say, but really, like, if it wasn't highly rewarding and it wasn't urgent feeling for you, why would we do it?
Yeah, I get
Right?
it
It's so much
completely.
work.
Yeah.
And so yes, you do, but you're so primed for that oxytocin hit, right? And so the leaking is because you're getting a surge of oxytocin. And for sure, in like especially those first 6 weeks postpartum, you're like in the shower.
Yes.
And you think you hear your baby crying,
Yeah.
but they're not actually
They're not
crying, but you're leaking.
Yes.
Right? It's how primed are you to oxytocin. And then later on, you have a 6-month-old, you have a 9-month-old, maybe it takes 30 seconds of sucking to get the letdown to come, because that's very energetically wasteful, right? It's wasteful to just be leaking milk everywhere.
Yeah.
And so it does, as you get further postpartum, it takes a little bit more effort on the baby's part to really get things going, just so you're not wasting the milk. Do you know what I mean?
Absolutely.
Yeah.
I want to speak about transitioning to bottle.
Yeah.
And that could be different for everyone. Some
Yeah.
people want to do it like just continue chest feeding, breastfeeding as long as they can. Some people, because they have to return to work or for any reason, if it's not possible, they want to transition, right?
Yeah.
And it can be very difficult.
Yes.
Is there a right time to transition or is there a right way that they can transition?
Yeah, that's a great question. And I'm always a little bit hesitant to say that there's a right time, right? Because babies need bottles for all sorts of reasons that are often completely out of the control of the parents.
Yeah.
Right? And so many times I see people where in the beginning the baby is only taking bottles, having trouble with the breast. And then I get a call from them like 4 months later where they're like, oh my God, we tried a bottle and the baby won't take the bottle anymore. So I can give like general guidelines with the big star that there's people introduce bottles at all times for all kinds of reasons, and there's nothing wrong with that. And it's lots of babies go back and forth without issue. So what I will say is that in general, newborns, like under 6 weeks old, are much more likely to take a bottle than older babies are. So if you are planning on doing bottles regularly, I usually recommend introducing them at the latest, like 6 to 8 weeks. Because after that, they have opinions. And sometimes the opinions are like, what are you doing? I don't want to have anything to do with this. And then I also recommend keep the bottle in their repertoire once or twice a week, just so that they remember what it is, right?
Got
Because
it.
just because they take it at 6 weeks doesn't mean they'll take it at 3 months if they haven't had it for another 6 weeks, right?
True.
So if you want to have, just, if you have an appointment or whatever, like you want to have it in their repertoire, give it to them every, couple times a week, just so that they have it in their remembering.
True.
So that's for if you've not introduced a bottle. The other thing is that you want to make sure that you have a bottle where the baby is able to have a wide open mouth, right?
Okay.
Because they have to have a wide open mouth at the breast.
Yeah.
We want them to have a wide open mouth at the bottle as well, so they're not used to getting milk like this.
You mean the ones that are like the big ones?
So it depends on the baby. It depends on the baby, right? So what you really want to make sure at the end of the day is that they're wide, right? And if your baby can be wide on whatever bottle you have, that's all that really matters at the end of the day. Different shapes are more conducive to being wider than others. Like the ones that I don't really love, the ones that kind of like bubble in almost, like there's a little
Yes.
bobble on the end and
Yeah.
then they come in and then they go out. I don't really love those. And I also don't really love ones that are like a nipple and then are really wide. Like where they're like whoop, that kind of shape. I usually I find it easier for babies to have ones that have a bit of a gradual taper so they can kind of gradually open their mouths. But as long as your baby is wide, that's fine. That's fine. That's what we're looking for. And then the other thing is that babies are very smart, and bottles can be fast and consistent. And so if their habit is that it's fast and consistent, and it's not fast and consistent at the breast, then they're going to have a problem with that, right?
Yeah.
And so you want to make the expectation of what's happening at the bottle to be the same as the expectation that's happening at the breast. So if you Google like paste bottle feeding, there's so many videos up there about paste bottle feeding,
Yes.
and that's typically what I recommend. We really want to like set the standard.
Got it.
Across
Because if it's
both.
going very fast, I've seen that it's like you keep the bottle parallel.
Yes.
And then it's not fully going in the nipple area,
Yes.
right?
Yeah. So they have to do the work of getting the milk to come.
Yeah.
And you want to, like, I would keep doing that for as long as you're doing bottles, just because you want it to be inconvenient.
Yeah.
You want the breast to be the more convenient option, right? If we're
It is actually, to be honest with you, I was pumping initially, and not because I had like issues or something, but I was just thinking like, okay, I'm pumping and I have milk, what to do? Just give it in the bottle, right?
Yes,
So
yeah.
he got comfortable with the bottle.
Yes.
And it was a bit of a hard work to make him more comfortable with the breast, but it happened. And then I was also worried that the nipple confusion should not happen, which is very common, I believe, right?
Yeah, it's sort of yes and no. I think newborn babies will suck on anything, really. Like they'll suck on your nose if you put it close to them,
Yes.
right? But if they are expecting something firm on their palate, right, with very fast milk, then having something soft on their palate that maybe doesn't quite reach as far back, or you have to open wider, like all of the. So the sucking reflex lives on the roof of the mouth where the hard and the soft palate meet. So if you run your tongue up along the roof of your mouth, you'll feel a texture change up there in the back. That's where babies need to feel stimuli to start sucking. And sometimes babies, they get the breast in their mouth. It's not quite that far back, but they're like, I know what I'm doing. And then they do the sucking to get the nipple back where it needs to be.
Yeah.
But if you're used to a very, long, firm bottle that goes right back there right away and the milk starts to come, then they're like, what am I doing? There's nothing here. I don't know what I'm sucking on. And then you get babies who are like, I don't know what to do. I don't know what to do. I don't know what to do. And it's because they're looking for that sensation on their palate and they're not getting it. So I don't know that I don't love the term nipple confusion, because it's not like it's just that they've come to expect something firm on their palate and that gets them to start sucking. But often if you just like shape the breast a little bit to get it further back on the palate or help them get wider or deeper, then they get that sensation on the palate and then they start sucking. So yeah.
I understand.
Yeah.
For those who are not giving a bottle at all, or they just exclusively breastfeeding,
Yeah.
and they want to give a pacifier,
Yeah.
that's a hard job, I think.
Yes.
Is there like a good pacifier and a bad pacifier? Not in terms of like I'm saying brand, but like the one that is not gonna cause again I'm saying nipple confusion because that's what I know.
Yeah. Pacifiers are
choose?
tools. Pacifiers are tools, right? And so I'm like, why are you using the pacifier? What's the reasoning behind it? And then that that sort of dictates how we talk about them. So if you're using a pacifier because you're like in the car and you can't breastfeed at that moment, but your baby's hungry and you're just popping a pacifier in, right? Or they're very fussy and you're like trying to get yourself to where you're going to nurse, that kind of thing. Then usually for those circumstances, I recommend a wider base pacifier so that the baby's mouth is open because they're getting ready to suck, right? Ready to feed. You're using it to like placate them until you can get to a space to feed them.
Got it.
Right? So wider at the base so they have that wide open mouth. If you're using it because the baby needs it to suck to fall asleep, there I'm always like, first we have to rule out hunger, right?
Yeah.
In the first situation, they're hungry, you're just trying to get to where you can feed them.
True.
But if you're like, the baby needs it to soothe, first we have to rule out that they're not hungry, right? Did you try at the breast and what did they do? And if I see this much more commonly in second-time parents than in first-time parents. Sometimes they're just genuinely tired, and they're like, "Sure, I'll suck," and then as soon as the milk starts to flow, they're like, "No, what? No, that's not what I wanted. I was just tired." So if you're having like that kind of experience, and you want to use the pacifier just for them to fall asleep, then I usually recommend actually the much smaller ones, the thin ones, because when your baby's sleeping, their tongue is supposed to rest up on their palate. And so if you have those teeny tiny thin pacifiers, they're going to be able to compress it up on their palate, and that's where their tongue would be anyways.
Do you mean the angled one?
Yeah, you can have an angled one or even the flat ones as long as they're like squishy
okay.
flat. Yeah.
Okay.
Yeah, because they'll push it up onto their palate.
I mean, I personally don't have a good relationship with pacifier. I don't want to be honest.
Yeah, and that's I didn't either, just because I was like, but then I'll have to take it away at some point.
Yes, that's one thing. And then I also thought, like, I see a lot of people give pacifier and then the baby's getting so used to it that they are always having it.
Yes.
They are wide awake, they are just in the car, there's nothing going on. But they're so used to having a pacifier. So I always thought, like, if I'm just shutting my baby's mouth with a pacifier, how am I going to see the cues that they're trying to give me?
Exactly.
I want them to put their hand in the mouth, drool, do the cooing, and I'm just going to put a full stop to all of that. So I never wanted to have a relationship with pacifier myself.
Yeah.
But because my audience is like all moms to be, new moms, and everybody has different ideas they might want to.
Yeah,
so
and it depends on the baby too, right?
Yeah.
It really depends on the baby. Some babies hate them anyways. But it depends on the baby, and it depends on the parents and what else is going on, and like I said, it's a tool, right? So if it's working for 2 minutes of sucking to settle them to sleep, or when you're in the car and maybe baby like absolutely hates the car seat, so you're using it as a comforting tool, like it's a tool, right? So at the end of the day, like I always say, you want to use your tools judiciously because you want to make sure you're not masking hunger cues, right? That's the biggest thing. You want to make sure you're not masking the hunger cues, but other than that, like use it as a tool.
As a tool, simply,
Yeah.
Do pacifiers affect the oral health and the structure of the baby?
They can. Yes, they can. So anything that is firm, because the breast, we have all these products that say they mimic the shape of the breast. Nothing mimics the shape of the breast.
Yeah.
The breast is malleable. It is, I'm sure everyone, you felt a breast before.
Yeah.
If you, at some point, maybe not everybody, but most people have felt a breast before, right?
Yeah.
It's malleable. It's soft, right? And so actually in the mouth, the baby is changing the shape of it all the time just by sucking, right? And so anything that is firm, that is pressing up on the palate, can have an impact on palate development. But again, you use it, sometimes we have to use it, and also like how often are you using it, and what else is happening with tongue function? Because when a baby is the other thing that develops the palate is the pressure of the tongue on the palate, right? So if a baby's sleeping with their tongue in an effective position, then the tongue is putting pressure up wide on the palate, the whole tongue, and that's what's going to give you that like nice broad palate versus if you have one of those stick pacifiers, like you know what I'm talking about, like the little cylinder pacifiers, that's like narrow up on the palate, right? So if they're sleeping most of the time with their tongue wide on the palate, and then very occasionally they have that in their mouth,
like some kids have throughout the night because it's soothing them to sleep.
Yes, so then there you might have an impact on palate development for sure, because it's constantly putting pressure up on the top of the mouth.
Got it.
Yeah.
Talking about the tongue, I would like to know about the tongue tie.
Yeah.
How does that affect feed? Like, how can we help the baby
Yeah.
get out of the tongue tie situation?
Yeah, okay. So I always like to preface conversations about tongue ties with the fact that tongue ties are very contentious. And if you speak to 3 different practitioners, you're going to get 3 different opinions about it. Personally, and then here's the other thing. Lactation consultants, like IBCLCs, cannot diagnose a tongue tie. They're not allowed. It's not in their scope. Because I'm a naturopathic doctor on top of the IBCLC, I can diagnose it, but I can't cut it. Like, I'm not able to treat it, but I can say, like, that's a tongue tie. You got to go see somebody about that. However, pediatricians and just like regular dentists don't get specific training in lactation or tongue ties unless they are seeking it out, right? Like tongue ties in infants, I should say, for dentists. Like it's a specific training. You have to go and learn more about it. It's not usually taught in just school. And actually, interestingly enough, pediatricians don't get any education about breastfeeding at all in their curriculum. So
What are you saying?
Yes.
They're pediatricians.
Yes. But here's why, right? Pediatricians have to be knowledgeable about everything, every infectious childhood disease, every nutrient deficiency, every like chronic childhood illness, childhood cancers, developmental delays. Like it's a very large amount of things that they have to know about, right?
Right.
And so breastfeeding is just not, it's not in their scope, right? It's in the scope of a lactation consultant. They just don't have the time to learn about it unless they've gone and learned about it after they've graduated. So that's my preface.
I understand.
I will give you my opinion about it.
Yeah.
And then just to say that like other people probably have different opinions.
Yeah.
I try to take a very functional approach to tongue ties. So to me, I'm not as worried about what does it look like under the tongue as I'm worried about how is the tongue functioning. In order to effectively stimulate the nipple, the sides of the tongue need to come up around. And it's actually in the front, it's the tongue and then the cheek fat that creates the suction on the nipple. It shouldn't be the gums and the jaw. Right? Like this part, your lips shouldn't be doing the job of the suction. It should be the tongue coming up around like this, called cupping, and the cheek pads.
If the infant's lip is trying to do the function,
Yeah.
is it like the baby will have inverted lips when they're
Yeah,
sucking?
they do this. And then you'll get those little white marks on their lips
Got
as
it.
well.
Got it.
Yes. Yeah,
so they should not have inverted
They
lips,
should be
right?
relaxed. They should be relaxed. And then the middle of the tongue does this. So that's the stimulation. So it's like a very complicated movement to do with the tongue. And so a tongue tie would be, there's tissue in the middle, right? And so what is the impact that it's having on that undulation of the tongue in the middle? So when I'm doing an assessment of a baby, I'm looking for like a full assessment of the anatomy. Like what does it actually look like under there? And if you're going to do a check of a tongue tie, you have to put your fingers in the mouth. You can't just look at a baby and be like, oh, maybe there's a tongue tie, maybe there's not. You have to lift the tongue up to get a full picture of what's going on under there. And I always want to evaluate the function. Because maybe there's tissue, but is it really stretchy and moving? And when we look at what the tongue is doing, it's doing what it needs to do. Do we need to do a release on that? In my opinion, no. But even if it's very far back and maybe it's hard to see, but it's really impacting the movement of the tongue, then I'm like, maybe we do need to do a release, right? So that's my approach to it. It's like I really need to do an individualized assessment based on what's happening in that specific baby. And it's I think it's a bit contentious because you will absolutely have people say that tongue ties don't exist. And you'll also have people say that every baby has a tongue tie and should have it cut.
I've heard like it's common. It's not very uncommon.
It's common to have tissue under the tongue. Whether or not that means it's a tongue tie, I think is a bit up for debate.
Got it.
Yeah.
So then I've recently spoken to a parent. They were told that their infant has a tongue tie and the doctor suggested that they have to get it operated.
Yes.
Right?
Yeah.
Is it always the case, or we can do something like infant chiropractor assessment?
Yeah. So this is why I went and did the craniosacral therapy training. This was one of the reasons, right? I almost never, except in very severe cases, I almost never recommend a tongue tie release without doing some kind of body work before. Because if you think about birth, labor, the uterus is pushing the baby's bum into their head.
Yeah.
Right? And lots of babies come out like this, right? And if we're trying to use the tongue, which is stuck under here, and everything is all tight, it's going to be hard regardless of what's happening in the mouth, right? And so if we can get babies into a much more open, much easier to extend position, then A, you'll know whether or not the release actually has to be done, and B, the release is going to be more effective because you can actually move, because the other piece of it is that if you were born in a cast and then you took the cast off and I said, catch this ball.
Wow.
You think you're going to do it, right? And so you also need to, if you're going to do the release, you need to be in a place where the baby can learn how to use the new tissue effectively, and you need to help teach them how to do that because they've never done it before. So there is a little bit of like retraining that has to go on with tongue mobility.
So, mom, it's very new for a mom to, this is something that a baby is learning as well as the mom is learning.
Yes.
None of them really know what's happening.
Yeah.
Is there any way that the mom can identify that the latch is not good?
Yeah, I mean, the first thing would be pain. So a good latch should never be painful. Never, not ever, not in the hospital, not when they're teething. A latch should never be painful. And I think that's a big myth. People are like, no, it just hurts for the first week and that's normal. Like, it's not normal. Something's happening here. And a lot of times it's a very easy fix where we're just going to change the positioning a little bit and the pain gets better, but it should never be painful. The other piece is so when you're looking at a latch, you want the baby to be able to use their tongue effectively, right? So we need to have a lot of tissue in the mouth, a lot of breast tissue in the mouth, because they need to stimulate it. And then also, they need the space to be able to move their tongue to swallow. So typically what I'm looking for in like a good latch, I say the good latch because even if it looks good from the outside, if it's hurting, it's not good. Something's going on. But you want the baby to be extended so that, think about if I were to say drink water, right? You do this.
Right, yeah.
Same thing with a baby. They have to do this. So you want them extended. And then you want your nipple aimed for the roof of their mouth, right? We said earlier that the sucking reflex lives on the junction of the hard and soft palate. So pretty far back in the mouth, that's where you want your nipple aiming for. So if you tip them, adjust them so that they're like this, when they open their mouth, you're going to have space to get your nipple into that spot where that's going to stimulate the sucking reflex.
I love how you're explaining. Even though it's going to be on Spotify, Apple Podcast, but for YouTube, people listening on YouTube,
I'm a hand talker.
Follow. No, that's lovely because I'm able to follow so much better.
Yeah.
And you know what? Babies are so smart. I can't stop saying this. When you said that, it's like they have to be like this, right?
Yes, yeah.
I recently discovered that side lying in the bed is the best thing to do, right?
It's the best.
And I can easily fall back asleep or nap.
Yeah.
And I used to see like he's always going like, his head is going back.
Yeah.
And I thought like it's not comfortable. Maybe it's going to hurt him. He's putting too much stress on the neck.
Yes.
And I tried to put him like straight, but he goes back to that.
Yeah, because this is the natural position for swallowing, right? Yeah. It's much harder to swallow. Like if you try it the next time you take a drink, try and do it like this.
I can already think about it like I cannot do it. It will not flow down my throat.
No, it's very hard. The other thing about newborns especially